graduates in pathology.
Than the glands.
Yes, ma'am.
Is that what you're saying? Suveta, are you
ma'am.
hearing yourself speak?
Yes, ma'am.
You're calling this gastric body mucosa and you're telling me that the foveolae are long. Hmm? Yeah, Dia?
No, ma'am. In body type of mucosa, there will be mainly parietal type of cells and also chief cells.
Excuse me,
So
ma'am, we are talking about the foveolar epithelium. Yes.
yes, ma'am.
What is the length of the foveolar epithelium as with respect to the glands in the body mucosa?
Ma'am, it will be shorter, not like the gland, not like the
Shorter. How
fovea.
much shorter?
Yes, ma'am. 25 is to 75 ratio.
25
Yes,
is to 75 ratio. All right. Vimy? Vimy's also disappeared?
No, ma'am. No, ma'am.
Huh? You're there?
Yes, yes, ma'am.
Yes, okay. So now please tell me on the left hand side, which part of the gastric mucosa is that?
This is fundic, ma'am.
Fundic means what? Hmm? Fundic means what? Is it the same as body? Is it like the antrum? Is it like the cardia?
Um,
You don't know,
no, ma'am.
right? So Dia is right that this is gastric body mucosa. Suveta also said that, but Suveta didn't know why she was calling it gastric body mucosa. Okay, body and fundus, there's nothing to choose from. They look the same. Okay, so please, this is gastric body mucosa, which is what you also see in the fundus. You have very short foveolae and you have the length of the glands is very long. Okay, it can be, you said 25% to 75%, it could be 30, 60, 30, 70, it could be, but it is really short foveolae, yes, into which many openings of the glands are. There's more than one opening of the gland into each gastric pit.
fovea.
Oh yes. All right. Anything else you see over here, Suveta, on the left hand side?
Yes, ma'am. The glands, ma'am.
Is there anything wrong with the gastric mucosa and the glands?
I don't.
Question, is there any normal tissue seen?
Yes, ma'am. This is a normal mucosa, ma'am. Gastric mucosa.
It's normal gastric mucosa, okay. Do you
The
see the
underlying glands.
muscularis mucosae here?
No, ma'am.
You don't. Anybody sees the muscularis mucosae?
Yes, ma'am. Yes, ma'am. I can see, ma'am.
Can you annotate, please?
Yes, ma'am.
That's all right. Yes. So you see here the muscularis mucosae. So you have got here the gastric mucosa. Yes. So let's see that now. You have the gastric mucosa here. And then you have the muscularis mucosae. And this part of it is all looking very normal. All of it is. This is crushed at the bottom over here. This is all crushed, so we can't see anything. But otherwise, this is absolutely normal. And there is something else that we can see perhaps over here, which we will have to see what that is. But because that is deep to the muscularis mucosae. Suveta, can you see this?
Yes, ma'am.
Well, I hope you can see that. I'm not so sure that you could see it. Now come to the right, and what do you see in 2B?
In 2B, it looks like the biopsy is taken from the antral part, ma'am.
The antral part, all right.
I can see the foveolar epithelium and the glands.
Okay, can you show me the glands, please? Yes,
Yeah, ma'am, this part.
that part.
Yes, ma'am.
You mean that everything from here to here is the glands?
Yes, ma'am.
Right. So now, can you tell me if everything is normal here? Do you see any
No,
normal
ma'am.
mucosa?
All glands don't look alike, ma'am.
They don't look alike. Okay. Can you see the muscularis mucosae?
No, ma'am.
No, you can't. So really, you cannot assess whether the glands reach right down to the muscularis mucosae, because that's what the muscularis mucosae tells you the thickness of this gastric mucosa. Okay, but what you can see, the muscularis mucosae should be somewhere around here. Sorry, I'm so sorry. The muscularis mucosae should be somewhere around here. Okay, and you see these very long pits. That means the foveolar epithelium goes all the way down. Not only that, it is branched. You can see branching, which tells you that this is antral mucosa. Okay?
Yes,
And then you have these where you don't see any oxyntic type epithelium. There are oxyntic means that it should have parietal cells and chief cells. At least parietal cells should be there. And these are mucus secreting glands. Okay? And you have the glands are as long as the gastric foveolar epithelium, which reaches down into the pits. What else do you see?
I can see inflammatory infiltrates, ma'am.
Inflammatory infiltrates. Very good. Anything else?
Some extravasated mucin substance.
Extravasated mucin. I don't see any extravasated mucin. I don't think there is any extravasated mucin. If you can see it, please mark it. Where is this extravasated mucin?
All this, ma'am.
That's not extravasated mucin. Okay, that's just some sort of serous exudate that, or even something that's crushed by the biopsy. That's not extravasated mucin.
Okay, ma'am.
So nothing else you can see. Anybody who wants to help her, Dia? No. What about you, Vimi?
And including the lamina propria.
Excuse me. Can anybody see this? Shweta? What is
Yes,
that?
ma'am. Intestinal metaplasia, ma'am.
Arey, wow. Now, what do you mean by intestinal metaplasia? What are you seeing, Shweta?
Goblet cells in the gland.
Which is so obvious. The rest of this foveolar epithelium is plain, simple, mucin secreting, non-goblet cell epithelium. And this one foveolar, a portion of the foveolar epithelium is sticking out over there, all right in the center, and it has got goblet cells. Okay. So now you see the high power of the epithelium on the left, which looks like what? What kind of epithelium is that?
It's a simple mucin containing
On
columnar
the
epithelium.
left side, what is this?
Right.
This epithelium,
Foveola.
foveolar, simple gastric type mucin secreting epithelium. And what are the glands?
This parietal cells.
So this is oxyntic
Oxyntic gland.
epithelium of the gastric body and fundus. Right. And what is going on over here on the right hand side?
There is intestinal metaplasia with goblet cells.
Right? Anything else?
The
Anything else? Shweta? Amy? Anything else? Dia,
Ma'am, I can see one nest. Ma'am, I can annotate that.
yes, please annotate. Yes, you can see nest. You can see a nest. Is there just one nest?
There are many nests beside it, and ma'am, they are having. Yes, ma'am.
Yes. What are they having?
Ma'am, they are having some
What?
of those cells are triangular,
There are many
and
nests.
yes, ma'am. Ma'am, some of the cells are triangular and they have scant cytoplasm. Uh, so I thought this may be nest of neuroendocrine cells.
Very good. Sueta, did you see the nests?
Yes, ma'am.
Oh, you did. So why did you not say that there were nests, Sueta? So Dia sees nests. Vimi, did you see the nests?
Yes, ma'am.
Vimi,
Can
yes,
see
you
it, ma'am.
did. Not only that, you can see these nests that are prominently seen at the surrounding some of these mucin type, mucinous glands of the gastric antrum. All right. So there, you have nests over there, and they have these very dense looking nuclei. Okay. The cytoplasm is not very conspicuous, and so you can't say anything. On the other hand, and this is sitting right in the lamina propria, along with lots of, do you see the eosinophils?
Yes,
There
ma'am.
are plenty of eosinophils over here, and on the left hand side here you can see absolutely normal fundic body type gastric mucosa. There's nothing wrong with the body mucosa or the mucosa on the left hand side. Okay. Now,
Yes, ma'am.
Suveta, what are you seeing here?
Can on the left side, I can see the muscularis propria, and there are
Muscularis propria.
sorry, muscularis mucosae, ma'am.
Yes.
And there are few glands beyond the muscularis mucosae which appears
Glands. Can you please mark the few glands beyond the muscularis mucosae?
they're not glands, ma'am. They're cells beyond the muscularis mucosae.
Shweta,
There is no
I think
glandular
that you
arrangement.
just have to make a good description, okay? Not glands. You say where are the glands, and then you say not glands. So make up your mind, Suveta. What are you describing? You can annotate. Can you not?
Uh, they are just cells, ma'am.
Do you see any glands at all?
No, ma'am.
You don't. Okay. Vimi, do you see any glands on the left hand side? Are you there, Vimi?
There is no glands, ma'am.
There are no glands.
Below the muscularis because it shows some sheets and nest of cells.
All right. Dia, do you see glands in this?
Ma'am, in case number 2A, in the right hand side, I can see glands which are normal glands. Ma'am, this portion.
Absolutely right. Absolutely right. You are seeing this is the portion of the deepest portion of that gastric body mucosa. Then you have the lamina propria, which is going to separate the gastric body mucosa from what? They are from what?
Muscularis mucosa separates body mucosa from the lamina propria.
1 minute.
Yes.
Muscularis mucosae separates what from what?
Muscularis mucosa separates lamina from the glands from the
Glands.
underlying submucosa.
Yes, so there is the gastric mucosa, which consists of foveolae, gastric glands,
Yes, ma'am.
lamina propria, as well as the muscularis mucosae, and deep to that, and you are seeing it over here, deep to that muscularis mucosae, you are seeing this piece of there is something that is proliferating over there. Okay?
Yes, ma'am.
Very good. And on this side, within the lamina propria, in case 2B, you are seeing nests, and these are just the high part of the nest that we were seeing. This is within the lamina propria, that is within the submucosa. Do you get it, Sumitra? Suveta?
Ma'am. Yes, ma'am.
Same with you, Vimi. Do you know that on the right hand side here you are seeing in case right here you are actually seeing the gastric mucosa. Yes, here. Oh, sorry, we went beyond that. Oh God, this is what you were seeing in the submucosa, and this is what you are seeing in the mucosa. And what's the difference, Sumeta? So, Suveta?
On the left hand side, can see these cells are mildly pleomorphic with a round to oval nucleus. They show a prominent nucleoli with the eosinophilic cytoplasm, ma'am. And
You
on
want to show me where these prominent nucleoli are, please? Show me the prominent nucleoli.
ma'am.
Mm.
Yeah, ma'am. This one, ma'am.
Where is the prominent nucleolus? Where are you marking? I can't see a prominent nucleolus. And where is your mark? Towards the left?
In this nuclei, ma'am.
Oh, okay. So is that the only one you saw, or you
No,
see
ma'am, many
lots and
nucleoli are
lots?
there.
Sorry,
Yes, ma'am.
many
Many are there, ma'am.
nucleoli.
Yes, ma'am.
All right. Let me ask the other two. Vimi, you see many nucleoli?
No, ma'am. It's actually a stippled kind of chromatin. No prominent nucleoli been
I
seen.
don't think it is stippled. I think that it has got a very clean nuclear membrane. There are a few small nuclei that are seen, right?
Small to inconspicuous.
Yes, but they are certainly not prominent. And these are vesicular nuclei. You can see the nuclear membrane very clearly. And in the center, you see a sort of pale nucleus, and all the nuclei are not of the same size. Yeah, I won't say that there is a lot of pleomorphism. Pleomorphism, it does not really come as to me as a diagnostic term that I would use, but there is anisonucleosis. There is also shapes are different. Some of them are round, some of them are irregular, some of them are oval. I would not say that there were prominent nucleoli, because the nucleoli just don't jump out of you at you. Okay, what are these cells? Are they the pattern of these cells, Sumeta?
They are arranged in sheets, ma'am.
Very good. They're arranged in sheets. Excellent. Now, if you come to the right, can you actually see the cytoplasmic borders on the left-hand side?
No, ma'am, it's not very distinct.
They are not distinct. Okay, very good. On the right-hand side?
On the right hand side, I can see round to oval cells with the
Round to oval cells.
cells with round to oval nuclei. And these cells have a salt and pepper type chromatin, and they have a prominent granular eosinophilic cytoplasm. They have distinct cell borders.
Salt and pepper type chromatin. I really cannot see the salt and pepper type chromatin. I know that these have got more or less uniform looking cells. Yeah, they're all round. The cytoplasm is extremely granular. It's very pink. Yes. And at the same time, what do you see? You do not see any nucleoli at all. And yes, the cells are denser than what you see on the right hand side. So if you're telling me that you can see a salt and pepper, you're imagining it. And this is typical, no? You know what the diagnosis is, and then you think you can see the features, but you can't see these features, okay? And you also see the goblet cells that are present in this whatever alveolar epithelium that you can see towards the right of this lesion. All right. So now, what is the diagnosis? Is there any, come on now, Sumeta, you have to do case 2A. Is there any normal tissue?
2A, yes, ma'am. You can see the normal mucosa and the glands.
And on the right,
mucosa.
There's gastric
on the right, there is antral mucosa. And abnormalities in the, yes, ma'am. And
the epithelium is essentially normal on the left side. There is intestinal metaplasia on the right
On the
side,
right side.
right?
Yes,
The
ma'am.
abnormality is in the submucosa
Submucosa.
side. Here, the abnormality is in the
Lamina propria.
lamina propria. Here you have sheets of epithelioid-like cells. Here you have nests of epithelioid cells. Yes?
Yes, ma'am.
And if you had to describe the cells, they have a moderate amount of light eosinophilic cytoplasm, oval or irregular, bland, pale, vesicular nuclei. You thought you could see prominent nuclei. I did not see them. There were no mitoses. Here, we said that, no? Small, medium, etc. Mitoses are not seen. And what else did you see? There was an inflammatory response that was present in the lamina propria, and there is no inflammatory response. This was something that I saw in my dentist's waiting room. It said a gum chewing kid and a cud chewing cow. They are the same yet different somehow. Ah, yes, I get it now. And what's the difference? It's the intelligent look on the face of the cow. So here we have two lesions, both of them looking more or less similar. So now we have to find the differences, and I have written down the differences for you. 2A, there is a mass lesion with sheets. In 2B, there was a nodularity in the stomach. Okay? You have sheets, you have nests. These are intermediate sized cells, these are small cells. There is anisocytosis here, this is monomorphic. Pale vesicular nuclei, and here the nuclei are dense. There is normal body mucosa, and here you have intestinal metaplasia and inflammation. So if you have to make some kind of differential diagnosis, what are your thoughts? Come on, so everybody knows that 2B is neuroendocrine hyperplasia stroke neoplasia. What is it in 2A?
Neuroendocrine tumor.
So, who said neuroendocrine tumor? Sueta?
Limpy.
Who, sorry?
Ma'am, Limpy, ma'am.
Limpy, you've joined us. How nice.
Yes,
So,
ma'am.
Limpy, you think it's neuroendocrine tumor. All right, very good. Vimy? Are you there, Vimy?
I think it's case 2B. I think it's a neuroendocrine hyperplasia since the nest
Know
of cells
about
are
case
same.
2B. I don't think that anybody is going to have any problem. What about 2A?
2A, a neuroendocrine tumor.
Neuroendocrine tumor. Limpy, you also thought it is neuroendocrine tumor. Suveta,
Yes, ma'am.
what?
It is a
Neuroendocrine
soft.
tumor. Dia,
Ma'am, I think 2A is a carcinoma, ma'am.
you think it is a carcinoma. All right. Would you like to explain why a carcinoma is arising in the submucosa?
Ma'am,
Little odd.
ma'am,
It's a little odd. Okay, very good. So now tell me which of these tumors, 1, 2, 3, 4, 5, would begin in the submucosa or would be mainly present in the submucosa?
Lymphoma.
Lymphoma. Who said lymphoma?
Suvaita, ma'am.
Suvaita. You said lymphoma. Okay.
Yes, ma'am.
Limpy?
It's lymphoma, ma'am.
Lymphoma. Right. Vimy?
Ma'am, lymphoma.
Lymphoma. Okay. Yes, Dia?
ma'am, I still think it may be carcinoma.
You may be. I'm just asking you which tumors would arise in the submucosa out of these 5 things. Anything can occur anywhere, but which would be a common occurrence? Everybody said lymphoma. Yes, it is very possible that it arises in the submucosa.
Yes, ma'am.
What else? Nothing?
Neuroendocrine tumor can also.
Neuroendocrine tumor, very good, can occur in the submucosa. Anything else? Unlikely that carcinoma and melanoma will occur in the submucosa. Right? What about soft tissue tumor? Or there are no soft tissue tumors that occur?
Can occur in the sub.
So then please tell me which soft tissue tumor? Which soft tissue tumor? Who said that, Suveta?
Leiomyoma.
Okay, smooth muscle tumor. Anything else?
Hemangiomas.
Hemangioma. Oh, okay. Anybody else? Limpy, which soft tissue tumor will occur in the stomach?
And cyst, ma'am. Glioma.
Cyst. Excellent. So, can be smooth muscle tumor or it can be cyst. Can either of them have an epithelioid appearance? Can you get an epithelioid smooth muscle tumor or an epithelioid cyst? Anybody
ma'am.
answer the question? Yes?
Yes, ma'am. Yes, ma'am.
Oh, excellent. So we have to consider neuroendocrine tumor, cyst, smooth muscle tumor, and lymphoma. It's very, very unlikely that you will get a carcinoma and melanoma, leaving the mucosa absolutely intact, unless it's creeping from somewhere else and coming into the biopsy, into the part of the stomach that has been biopsied. Okay? So those are our thoughts. So now let's take case 2A. Here is the CK. All right. So what is it? Come on, Suveta.
It is taken up in the epithelium. It's positive. The
Very good. And
gastroepithelium. And the glands.
excellent. So what about the tumor?
Tumor is negative, ma'am.
Right. Now tell me about smooth muscle actin.
It is positive in the tumor cells.
Smooth muscle actin is positive in the tumor cells. Would you like to show me where it is positive? Just ask for annotation. Ask for annotation.
Yes, ma'am.
Yes. Where is it positive?
Ma'am.
Okay. That's where you think. What about this? Is that also positive?
Yes, ma'am.
Yes.
It looks like a vessel.
That looks like a vessel. And so what you marked, what was that? It was a tumor cell? What do you think, Suvaita?
Yes, ma'am.
Tumor cell. Where is the nucleus of that tumor cell? Can you show me? Mark the nucleus of that tumor cell.
And
Right in the center. You don't think that it is that this is a vessel in which you've got something that's there? You've got a ring, you know?
yes, ma'am.
So what do you want to say? Is that positive or negative?
Negative.
Okay, so once again, it's not about doing the stain, it's about interpreting it. Very good. Now, what about S100 protein? Is it positive or negative?
It's negative, ma'am.
Negative. What about desmin?
It's also negative.
Also negative. What is this?
CD34
So is it positive or negative?
is positive.
And what's it on the right hand side?
It's not
What's that?
visible.
Sorry?
It's not visible, ma'am. Name.
The name is not visible. Oh, okay. What is it? Is it visible now?
Yes, ma'am. It is also positive. CKIT is positive, ma'am.
What is it? What is that? CKIT. What is CKIT? It's called CKIT. It is also known as CD117. What is that? What is that?
No, ma'am.
You don't know, Suvaita. Will somebody like to tell her? Limpy, what is that? What is CKIT? CD117?
Marker for GIST.
Or GIST.
It's a marker for gastrointestinal stromal tumor. So, Suvaita,
Yes, ma'am.
what is the diagnosis in this case 2A?
Yes, ma'am. Gastrointestinal stromal.
Gastrointestinal stromal tumor. Okay, very good. So it is an epithelioid variant of gastrointestinal stromal tumor. Dia, are you happy about the diagnosis?
Yes, ma'am.
Very good. Okay. And case 2B, there's no prizes for guessing this, but is this, I want to ask Suveta, has this been stained for cytokeratin? It's the same stain on both
Yes,
sides.
ma'am.
Has it been stained for cytokeratin? And I'm asking
Ma'am.
this for people in the chat box as well. Has this been stained for cytokeratin?
Yes,
You are
ma'am.
saying yes. What about Limpy?
No, ma'am.
No. All right. Vimy?
No, ma'am.
No, ma'am. Dia?
Ma'am, I think yes.
Yes. Okay. So now Vimy and Limpy, and Limpy, you were not here for a long time, so will you please tell Dia as well as Sumitra, I'm sorry, I got your name wrong. Suveta, why did you think that this is not stained for cytokeratin?
This is
Come on, Limpy. You said it's not
focal
stained for
positive.
cytokeratin, right?
Yes, ma'am.
Are you there, Limpy?
Yes, ma'am.
Very good. So now tell them why you think that this is not stained for cytokeratin.
It's neuroendocrine tumor, ma'am.
So neuroendocrine tumors don't stain for cytokeratin.
No, ma'am.
Oh, really? No, that's
Oh,
not
no.
the reason. Vimy, why is this not a cytokeratin immunostain?
Ma'am, this epithelium is not taken up the normal epithelium is not taken up the stain.
Absolutely right. This is not a cytokeratin stain because you have so much of the epithelium. Do you see the epithelium at all, folks? This is all epithelium. Do you agree, Suveta, that this is epithelium?
Yes, ma'am.
Yes. What does cytokeratin stain?
Epithelial cells.
Epithelial cells. And is this positive or negative?
Negative, ma'am.
Negative. So this is not a cytokeratin stain. So Limpy, you were right for the wrong reasons. Okay? You felt that the tumor, and it's obvious that there is tumor over here, that this tumor has been stained, and this tumor is a neuroendocrine tumor, and neuroendocrine tumors do not stain for cytokeratin. My dear Limpy, they do stain for cytokeratin. Has anybody answered in the chat box, Bonita? What did most people say?
There is a mixed answer, ma'am. Some have said yes and some have said
Some had said no. Now I hope everybody knows that this. So what stain is this then? Dia, now what stain is it?
Ma'am, synaptophysin or chromogranin.
Chromogranin. Excellent. It could be one or the other. This is a chromogranin stain, and it's showing you two things. It is showing you that those nests that are seen over there, small and large, are positive for chromogranin, and also that there is neuroendocrine hyperplasia. You can see so many of the foveolar and glandular epithelium showing you more neuroendocrine cells than you expect, and small areas of these nests are also being stained by chromogranin. Has everybody got that now? This is not a cytokeratin stain. Okay, we've got other areas from this. I didn't show all of those in the H&E because there were fragments. This is also chromogranin, and this is cytokeratin, and you have seen that there are small nodules and there is a tumor that you can see. All right. Again, you see in different areas lots and lots of small little nodules, and you have neuroendocrine hyperplasia in the glands. So this is a case of atrophic gastritis. There was partial gastric atrophy, with incomplete intestinal metaplasia, neuroendocrine cell hyperplasia, microcarcinoidosis, because there are these small little areas, and a type 1 gastric carcinoid. I'm not going to tell you about type 1 gastric carcinoid and all of this. This is a slide seminar. So all of you please go and read about type 1, type 2, and type 3 gastric carcinoids. Okay? So fine. Now we've come to the second last case, which is case number 3. And who's going to take this now? Vimi? Yes, Vimi, you can do this.
Ma'am, case number 3A, 30-year-old female, excision of a painful 3 centimeter mass in the supraclavicular fossa.
Okay.
And case 3B is 88-year-old male with recurrent cutaneous subcutaneous swelling over the left knee. A bleeding lesion was excised from the same site 8 months before the present time.
All right. Now, Vimi, you just have to tell me what is the similarities between these two. Okay. What are the similarities that you're seeing between the two?
Both are showing dilated spaces with hemorrhage.
Okay. So there are dilated spaces in which there is blood. Yes.
Yes.
All right. Any other similarities that you see?
There is no normal tissue in both.
All right. Now you can see the similarities, right? Which you said that there are some dilated spaces filled with blood. Is that really observationally correct?
Yes, ma'am. It's filled with blood, so I'm thinking it's a vessel, blood vessel.
Okay, so you think that these are blood vessels because they are filled with blood. Do you notice something on the right hand side that is case 3B? Yeah. There are other spaces, right?
Yes, there are multiple.
There are other spaces. There are spaces, some with some blood in it and others not. And you also see some spaces that are very almost like cracking artifacts in the tissues. You see that here? You also see on this side. Okay? But this space on the in 3B is a very well defined space. You can see all these spaces are extremely well defined. When you see a space here on the left hand side, except for one space which looks relatively well defined, yeah, these are just like areas of hemorrhage. They are not spaces that are filled with blood. You see the difference between the two?
Yes, ma'am. Yes.
This is observationally very, very important. This looks like just on the left-hand side, pure hemorrhagic areas in the tumor. There are spaces. You can see that there is a space even on the left-hand side, but they are not filled with blood. Okay. Now, what else do you see? More or less the same thing. Yes. And you are beginning to see now what is on the left-hand side, please, Vimi. What is this?
Ma'am, on case 3A, I'm seeing blood vessels which are surrounded by spindle cells.
Spindle cells, yes. Anything about the blood vessels that you need to note?
The vessels appear some hyalinized. The wall appears.
There are many blood vessels, and you can see them at the bottom of this, and they are all showing you a hyalinized wall. On the other hand, on the right hand side, yes, you see spaces, there is blood, but you do not see hyalinized blood vessels. Is that right?
Yes, ma'am.
Very good. Now look, once again comes up the space on the right side, and there is blood that is present in the space. On the left hand side, what do you see?
There is
it's spindle, yes.
Spindle
and it is
to
arranged
avoid cells. Some are having pale eosinophilic cytoplasm and some appears clear cytoplasm.
Excellent. Very good. Yes, Vimi. And the arrangement of the spindle cells is in?
There is a fascicle.
Yes. So the spindle cells are in fascicles, and once again, a fascicle is a bundle.
Disordered fascicles,
Yes. And
irregularly arranged fascicles.
yes, but what is a fascicle? Can you define a fascicle, please, Vimi? Fascicle
Fasc
is a bundle made up of elongated cells in which all the cells are running parallel to
parallel.
each other and parallel to the direction in which the fascicle is running. Okay? So
Okay,
you
ma'am.
have got fascicles. Maybe there's a little bit of a herringbone pattern over there. Okay? But you were absolutely right. There are areas which have got clear cells and others that are frankly spindly. On the right hand side, you see something else. And what is that? There is a condensation of cellularity
Around
around,
that lumen, ma'am.
a
Around that
condensation of
spaces,
cellularity around the
spaces that
bases.
spaces filled with blood.
Very good. Yes. And now you can see both at reasonably similar power. And what do you see?
Um, the similar observation, and in case 3A, there are a lot of smaller vessels
Hmm?
with
I,
hyalinization
yes,
and
excellent.
spindle cells and tear cells, which is arranged in slightly haphazard fascicles,
Mhm.
like short interlacing.
Here it is, looks like sheets, no? Except that it
Yes,
may
ma'am.
be
Sheet.
that the fascicle is actually cut at right angles, and that's why the cells don't seem to have very spindly nuclei. So that happens when you
Okay.
have a broad fascicle that is cut at obliquely or at right angles. And on the right
Yes,
hand
ma'am.
side, there are more sheets. There are not too many fascicles. But what do you want to say about the space? You said that you thought they were blood vessels, these spaces. Do you think that these are vessels, Vimi?
It doesn't have a proper endothelial lining. It's showing.
So these are non-endothelial lined spaces, but they are sharp spaces. It's not just some crack over there. These are actual spaces. I mean, and you recognize them as being spaces. Okay, you see it again here on the right hand side. And on the left hand side, you see hyalinization. You see these vessels that are almost showing you what you see in glioblastoma. That's endothelial conglomerates. Yes,
Glomeruloid microvascular proliferation.
exactly. Microvascular proliferation is being seen. And you see these cells here looking, the nuclei looking round. Why? Because it's a fascicle that has been cut at right angles. And
Yes, ma'am.
on the right hand side, what do we see? We see the clinging of these of the cellular areas. They cling around these very definite spaces, but the spaces are not lined either by epithelium or by endothelium.
Mm.
Okay, you can see that. And now you can see the hypars of both. The hyalinization of the blood vessels on the left side. And what are you seeing on the right side now?
The cells appears forming a nest, vague nest.
They're not in nests, they're more in sheets, no? But they are nodules. You see the nodules because you were able
Nodules,
to
ma'am,
see that.
nodules. Mm.
They are nodules at the center of which you are seeing these spaces. So there were nodules, and there is this degree of pleomorphism. It's not marked, but it's there. You do see the variation in nuclear shape, size. Quite a number of them are spindle cells, but some of them are not spindle because their nuclei have taken many different shapes. Some are round, those may be fascicles that are cut, but the others are not like that. See again this nodularity that you are seeing? Here there
Yes,
is
ma'am.
monotony. On the other side, that is not monotonous. And then you look at it at high bar. And now you can see these nuclei on both sides very, very, very close. And these are spindle, or when the fascicle is cut at right angles, they're round. But what are
Mm.
these? Apart from being spindle, some of them are
Market pleomorphism for the
it's not
nucleus.
these nuclei. Some of them are triangular, almost or irregular, which suggests that their cytoplasm cannot be spindle, right?
Yes, ma'am.
Cytoplasm is probably stellate. It's not all over. There are some stellate cells. Many of them are spindle, but there is some degree of stellateness to the shape of these cells.
Yes,
So,
ma'am.
yeah, so this is at high power. So now let us, somebody wants annotation. I don't know who this is, but I'm not going to approve it because it's somebody else. Okay. Now the periphery of case 3B. What do you see at the periphery of case 3B?
Ma'am, in case 3B, there is inflammatory cells
Ah, at the
predominantly
periphery.
composed of lymphocytes, eosinophils, plasma cells,
Yes.
and some
You see this? This
hemosiderin-laden
is a
macrophages.
nodule, no? A lymphoid nodule. There is a
Yes,
mixture of
ma'am.
lymphocytes, plasma cells, eosinophils, but there is a clear lymphoid nodule. At the
Yes, ma'am.
this nodular lesion at the periphery has got a lymphoid nodule. This is the low power, this is a higher power view of the same. So now, what do you think? Come on, Vimi. Case
Ma'am,
3A.
3A is a vascular lesion, which is having this
Okay. Any other
ovoid
thoughts?
spindle
A
cell,
spindle
glomus
cell
tumor,
vascular lesion, right? That's what you think?
like a perivascular lesion.
No, sorry. Are you saying that this is a lesion with vascularity or is it a vascular lesion? Is it arising from vessels
This is a
or is it a
vascular
vascular?
lesion, ma'am.
No, so what do you mean? A lesion with it is actually arising from an endothelial cell. Is that what you're saying?
No, ma'am, it's not from the endothelial cell.
Then, so when you say it's a vascular lesion, what do you mean? Every lesion is vascular, no?
It is arising from the periendothelial cell.
So you think it's a hemangiopericytoma, or it's a myopericytoma, or it is a what?
Glomus tumor, ma'am, glomangioma.
Glomus tumor. Acha. Okay. Very good. Anybody else? Limpy? Limpy. Limpy is lost. Are you there, Limpy?
Yes, ma'am.
So tell me, what did you think about
Yes, ma'am.
case 3A?
I thought it was neuro.
I can't hear you, Limpy. It's a what?
I thought it was schwannoma, ma'am. Schwannoma.
I can't hear. What did you say?
I thought it was schwannoma.
It looks like a schwannoma. All right. So you think it's a
Yes,
schwannoma.
ma'am.
Very good. What about you, Dia?
I thought it's a vascular transformation of the lymph node, probably a nodal angiomatosis.
Nodal angiomatosis. All right. And we have now Suvaita. Suvaita? Suvaita? She's gone. Have we lost Suvaita?
I think she's not there, ma'am.
Yeah, okay, we've lost Suvaita. All right. So, let us start from the beginning. All right? Is this congenital or acquired? Come on, Vimi. Vimi, are you there?
Acquired, ma'am, acquired.
Right. Next.
Pathological,
Yes.
neoplastic.
Right, you think it's neoplastic. All right, then.
It's
Benign or malignant?
benign tumor, ma'am.
Benign. All right. It's cellular. So is it benign or malignant? So now we have to go and find out what it is, right? We have to make a description. So it is a circumscribed. You know the history. It was a painful mass in the neck, and you described it right. There's fascicles of spindle cells in a cellular and loose arrangement. You saw the clear cells over there, and there were foci of hemorrhage. Also, what has not written over here, that there are these distinct blood vessels which have a hyalinized column. So, now tell me what we are describing. What are we describing? Huh? Come on. Circumscribed pain. Yes, please. What?
We are describing a schwannoma, a benign dural tumor.
So, I describe it and you make a diagnosis of a schwannoma. And that is exactly what I keep telling you on and on and on. A description should be such that somebody who is blind can actually make that diagnosis. You saw what I saw. Isn't that right? You saw what all of us saw, but you came to the diagnosis of what? A vascular tumor. Yes, pericytoma. But when I described it, and is my description made up, Vini? You had the same description. Yes or no? What, Vimi? Have I made up this description or did you describe it the same way? Vimi, you also
I
described it.
actually didn't describe it. It as a cellular and loosely areas, ma'am.
Yes, so? No, I'm sorry, Vimi, but how did you reach the diagnosis of a schwannoma? The same way that when I described it, right? So have I described this wrong?
No, ma'am.
No, ma'am. You saw what I saw, and yet your observations and your description were different from what I described it. So I must say, Limpy, you made the diagnosis of schwannoma. That is excellent. So this is, yes, a schwannoma. It is it is not a lymph node. There was no lymphoid tissue over here. It was circumscribed, yes. But many things are circumscribed and they're not lymph nodes. Okay? So what actually is the diagnosis? It is a schwannoma with degenerative changes. Okay, now this is not something that you should not be able to recognize, provided you make the right observations, the right interpretations, then you can make the right diagnosis. Agreed with me? Do you agree, or do you have some questions? Ask me now. Do you have any questions, Vimi? Vimi, have you disappeared or are you there?
No, ma'am. It's right. Yeah.
So you have any
Yes, ma'am.
questions?
I'm not able to unmute myself. That's right. Yes, ma'am. It's schwannoma with degenerative. I made a mistake. Yes, I agree with the diagnosis.
Okay. And the only reason that you didn't make the diagnosis is because you didn't make you made the right observations, but your interpretations were not consonant with your observations. All right. So now we come to 3B. Come on, Vimi. You see this? These are
Yes, ma'am.
yeah. Now come on. Just like we described there, just put it into one sentence. What? Not one. Yes, one sentence. What you are seeing, and then you will reach the diagnosis. Come on. This is an 8-year-old, so it's a child with a recurrent lesion in the arm, which is nodular, which has cells with a minimum amount of pleomorphism. It is largely spindle, focally stellate, has got very distinctive spaces within the lesion in which there is hemorrhage, and these spaces are lined by endothelial cells. At the periphery, you are seeing lymphoid tissue. Now, come on, I've said the whole thing. So, what is it, Vinny? nodular soft tissue lesion, which is recurrent, which is minimal pleomorphism, surrounded by somebody must be saying something in the chat box. What is in the chat box? What's the diagnosis?
No response so far, ma'am.
Nobody so far. I think they've all gone to sleep. Deepa, what's the diagnosis? No? Limpy? Limpy?
Ma'am, are you asking me?
Yes, anybody. Come on.
Ma'am,
Ma'am,
there are two
I thought it is a case of epithelioid hemangioma.
Epithelioid hemangioma.
Yes, ma'am.
Yes. A hemangioma, who's that, Dia? Is it
Yes,
Dia?
ma'am.
Who said epithelioid hemangioma?
Ma'am, I said.
Who's the I?
Ma'am, Dia.
Dia. Dia, and hemangioma is a tumor of what
Blood
cell?
vessels.
Don't say
Of
blood vessels.
endothelial cell.
Endothelial cells. So you see spaces lined by endothelial cells?
Ma'am, I thought the blood vessels were lined by endothelial cells.
Blood vessels. Which blood vessels? You don't think that these spaces are part of this tumor, or they're just there for just by the way? But because it is such a characteristic part of this tumor, right? And they're
Yes,
not
ma'am.
lined by endothelial cells. So it's a bit odd, no, for it to be blood vessel tumor. But anyway, you said blood vessel tumor.
Yes, ma'am.
Right, very good. What about Vimy? What did you say, Vimy? Vimy is unable to unmute herself.
Ma'am, I thought it was a caposiform hemangioendothelioma.
You also thought it was hemangioendothelioma. Limpy?
Ma'am, epithelioid hemangioma, ma'am.
Epithelioid hemangioma. Okay. Who else is there? Suvaita.
Yes, ma'am.
What?
I thought it was epithelioid hemangioma, ma'am.
See, for anything that has to be of vascular endothelial origin, you should be seeing endothelial cells that are lining something. And if you're all saying that it is benign, then there should be vascular spaces lined by endothelial cells, and they are not there. And you said that they were non-endothelial lined spaces. Okay? So, all right, it is acquired, it is pathological, it is neoplastic. Question is it benign or malignant? So let us find out what this shows. It shows plump cells with vesicular nuclei, some nuclear irregularity, and no mitotic figure. So all of you think that it must be benign because everybody has said that it is hemangioma. There are spaces containing blood but not lined by endothelial cells. And there's lymphoid follicles at the periphery, and this is a nodular lesion. It is recurrent in an 8-year-old child, and there is only one tumor. If you had put all this into your Google, you would have known exactly what it is. And this is an angiomatoid fibrous histiocytoma. Now, I do not think that if you didn't make the diagnosis, you are wrong. But if you had made all these observations and put it together, one thing I can assure you, you should not have reached the diagnosis of an epithelioid hemangioma or hemangioendothelioma, because there are no endothelial lined spaces, number one. And for epithelioid hemangioendothelioma, you may not have epithelioid lined spaces, but you should have blister cells, cells with blisters, some of them actually containing a red blood cell. Okay, so never mind, you didn't make the diagnosis, but this is an angiomatoid fibrous histiocytoma. Now you all have this. You already have these pictures. So go look at them, read the books, and it will tell you what this entity is and how it looks. Okay. So here, nothing helps, no immunohistochemistry helps. So you can do everything. You can do, here you are, 31, 34, if you thought that this was an endothelial cell tumor, it is not. It's not marking with SMA, desmin, S100 protein. If you want to do something and you don't need it, it is so typical. You can do an ATF Krebs assay, which we did, and it was possible. But this is not because we needed to do it. It was just done as a matter of course. Okay, so this is a epithelioid. I'm sorry, this is not an epithelioid hemangioma or hemangioendothelioma. This is an angiomatoid, and it is called angiomatoid because it resembles some kind of angioma-like thing, but it is not of vascular endothelial origin. Okay, and we can go and read about what it is. Now, last, who's going to take this? Limpy, you have arrived on the scene. Come on, Limpy. What's the diagnosis in this 48-year-old male? Are you there, Limpy? Limpy? Has she disappeared?
Limpy, please unmute yourself.
Are you there, Limpy?
Yes, Limpy is there, ma'am.
I don't know.
Bad connection. All right, we'll go back to Dia. Come on, Dia.
Yes, ma'am. A 48-year-old male with a specimen of distal partial gastrectomy. Gross examination showed a polypoid mass measuring 2.5 centimeter in size on the lesser curvature.
Okay, come on. Describe
Ma'am?
quickly. Yeah, what happened? Limpy's back? No.
Ma'am, the
Yes,
Limpy,
ma'am.
are you
Limpy is
back?
back.
sorry, ma'am, connection is bad.
Yes, Limpy, come on. Yes, come. Loudly now.
Yes, ma'am. This is ma'am.
No, Limpy, your voice is cracking. Limpy, we can't hear you. Your voice is cracking.
Ma'am, specimen. Hello, ma'am. Ma'am, this is T8 year.
Yeah, Limpy, we can't hear you. Your voice is cracking. I'm sorry, but I think we'll have to get on with somebody else, okay? Sorry about that, but your voice is cracking. Can we ask Dia to do it?
Yes, ma'am.
Just mute her, please, Ruchi. Come on, Dia. Jaldi.
Ma'am, I can see the mucosa, which are having those gastric pits,
Ah,
and below them there are mucous glands, which are dilated focally dilated, and we can also
Dia,
see in
you
the
are
middle.
once again being irrelevant, okay? Is that the real, are those the observations that one needs to make? No. The next thing you would tell me that there is some congested vessels in that mucosa. What is the observation that you're making here?
बघायचं आपण ओ लिहितोय आ लिहितोय काय लिहितोय ते
Huh? What is the observation that you're making here?
आपलं लक्ष नसेल तर सगळं चुकणार
Ma'am, someone is speaking, I think.
No, it doesn't matter. Come on now, they will get muted, but please.
Ma'am, there are diffuse. Ma'am, I can see this one is the muscularis mucosa in the middle portion, and above that there is diffuse infiltration by mononuclear inflammatory cells, and there are also some bluish areas in the upper portion.
I mean, all of this, you can actually make out something? Huh? You can make out something, Dia? That then you can see inflammatory cells and all that? Really? Let me ask the other two. Can you make out something here? Do you see anything? How do you recognize a cell?
It just looks like some necrotic material.
Who said that?
Suvaita.
Sueta. So this is faceless?
Yes.
Yes, it's just a sheet of necrotic, and I would use the word devitalized tissue. Yes or no? There is an apt word to be used over here. It is devitalized tissue. All necrotic tissue is devitalized, but we normally use the word necrosis, and we understand this. This thing is not only devitalized, but it is got lots of these small little blue, as you said, which are probably colonies of some sort, right? So it is devitalized tissue which seems to be colonized by organisms. Now, what is that devitalized tissue which is colonized by organisms? What is it called? Is there a word for it? We may not use it in pathology, but the surgeons use it all the time. What is it called? Anybody? Slough. Have you heard of the word slough?
Yes, ma'am.
Yes, and you see it, no, in ulcers that are chronic and which have all this devitalized tissue on top and often colonized by bacteria. That's what this looks like, okay? Except, what is it looking like here? It's like a volcano, no? It's, you see that there is an ulcer here. It's an obvious ulcer. Yes or no?
Yes, ma'am.
Yes, and this ulcer has got almost like an everted edge. It is like a volcano that is seen over here. See, you can see this? Here is the mucosa, and it is like an ulcer with an overhanging margin. Okay, the edge is undermined, but this is an overhanging margin. You can see that. It's an eruptive necrotic material. Do you agree, Dia?
Yes, ma'am.
Yes. And look at it. You can't see anything. You can't see cells. You can't see inflammation. Except that somewhere near the base you might see these cells which you think are inflammatory. But within that eruptive kind of necrosis, there's nothing to be seen. Look at that. Yeah, at the edges here towards the base, where you may see a little muscularis mucosae that is remained. The rest of that mucosa is lost, and you see this huge necrotic tissue. Now here, towards where you can actually see, you see the neutrophils. Yes or no?
Yes, ma'am.
And the base shows a little bit of fibrosis and granulation tissue. So now come on, tell me, what's the diagnosis? See how beautifully you can see this, an eruptive sort of it's a devitalized tissue. Now, if we had to describe it, what would we say? There is an abrupt line of demarcation, right? So when we say what is the relationship of the normal to the abnormal, it's an abrupt line of demarcation between normal gastric mucosa and the lesion which pouts above the gastric surface. You know, that is the word. It is pouting out above the gastric surface. You can see it in both these pictures that I put up here. And it's exactly what you're seeing. Faceless, basophilic, you were right, Dia, when you said it was basophilic, granular tissue in which no cellular characteristics can be discerned. Yes, there is an acute exudate over the better preserved areas of the mucosa. The base of the lesion is the submucosa. We said that, no? Because the muscularis mucosae formed a line. We could see that. So that's the base of the lesion. Okay. This is the floor of that ulcer. And there's a vague appearance of an inflammatory infiltrate in the base, but you really cannot see much about in this lesion. So now, what are your thoughts? Let's ask this question. Why can't we see the cells of the lesion? Dia, you want to say why we can't see it?
Because of necrosis.
Because of necrosis. But what kind of pouting necrosis can cause this? Anybody has any thoughts? Anybody's writing anything in the chat box? As I told you, it's devitalized. Now, why do things get so devitalized that you can't see anything, no outlines. You think this is liquefactive necrosis, or this is coagulative necrosis, or what? Certainly this is not liquefactive. Yeah. Get
No
I can't
response
see
in
any
the chat.
outlines. Yes, somebody was answering. What? Who's that? Limpy?
Ischemic.
Suvaita, who?
Ischemic, ma'am.
Infection.
Ischemia, yes, quite possible. So, this is it, no? The lesional tissue must be completely devitalized. Oh, yes, it can be ischemia. So, why did it become devitalized? Now we have to think, no? And there are some causes of devitalization. One is chemical, the other is enzymatic. Chemical can be acid, alkali, organophosphorus, whatever. Yeah. Enzymatic, you can get this sort of thing in pancreatic fat necrosis, enzymatic digestion by E histolytica, burns. You know that the thing becomes completely devitalized. Yes or no? So that's physical. Vascular, you were right. Ischemia, infarction, infections. Fungi such as mucor and conditions such as cancrum oris, carbuncles in people who have diabetes. And of course, if tissue is not preserved, autolysis also causes complete devitalization of tissue. Okay, now what's the importance of this? So when somebody says causes of necrosis, okay, these are the causes of necrosis and they must come into your head. Now, Dia, tell me out of all of these, and these are the causes of necrosis. See, there is a reason why we should be studying general pathology much more carefully than we do. We must do. It's written there in your general pathology chapter on necrosis. What are the causes of necrosis? We don't pay too much attention. No, yes, okay, chemical, enzymatic, physical, this and that. All right. Now tell me, Dia, pick one. Why do you think that this stomach lesion is showing you this kind of devitalization? Come on, Dia.
Ma'am, maybe because of corrosive injury.
Corrosive injury. Ah. Anybody else?
Maybe due to
Anybody had any other
infection.
thoughts? What was your diagnosis before this discussion? Dia?
Maybe.
Ma'am, I could not reach up to a diagnosis because I was not much seeing the cells.
You couldn't see the cells because they're not there. And you don't think that I gave you something which was so badly, sort of fixed and so badly processed that I expected you to see something in that kind of, yeah. Okay. What about you? What is your diagnosis, Vimi? Vimi, are you there?
Ma'am, I just appreciate that extensive areas of necrosis, not definitive diagnosis.
No definite diagnosis. Okay. Did you even think what could cause this kind of
Is
necrosis
necrotizing
in the
lesion.
stomach?
Infection?
Did you have some ideas about what could cause it?
Any infection, ma'am?
Infection. Acha. Suvaita?
Ma'am, I thought it could be some infection, infectivity,
Infected.
fungal infection.
All right. And I don't think Limpy is there. Is Limpy there?
She is there.
Yes, Limpy. Tell me. What did you think?
Ma'am, if ma'am, but I think inflammatory lesion of stomach, ma'am.
You thought it was inflammation, good, but what was the cause?
Infection. Ma'am, it is inflammatory lesion of stomach.
Necrotizing inflammatory lesion, excellent. The cause of which is
Infection. Fungal
fungal infection. Very good. So you thought it might be fungus. Excellent. So it is some kind of overwhelming necrotic lesion in the stomach, and we need to find out something more. Okay. All right. So this case cannot be diagnosed unless we have a history. There has to be a context, okay? So I'll tell you the history, and here is the history. The patient was a farmer from the Konkan, and he had some fever and jaundice which he recovered from 4 months prior to his present complaints. Now he's complaining of melena, and he had a scopy done at a hospital in Mumbai which showed a gastric ulcer. See? And he was bleeding from that ulcer. So an injection was given at the site of the ulcer. Well, we can only assume what that injection was. Could have been a sclerosant or something of that sort. It could have been epinephrine. Okay, so a sclerosant, possibly containing epinephrine, was injected on 2 occasions locally. Patient then consulted at a municipal hospital in Mumbai because he was still getting melena. And the sclerosant was injected for the 3rd time. And once again, on follow-up, there was, he came for a follow-up, and then there was this ulceroproliferative mass, as they called it, in the stomach. Biopsy and brush cytology was done. The biopsy was reported as autolytic tissue. You can imagine why. It was not autolytic, it was completely devitalized necrotic tissue, but the cytology was reported as a signature cell carcinoma. And so they decided to do a gastrectomy. So now what is the diagnosis? What is the etiology of the necrosis in this case? You think it's chemical, enzymatic, physical, vascular infection, or autolysis? What do you think? Dia is right. It is a chemical. Okay. So it is ischemic devitalization of the gastric wall due to the iatrogenic effect of a vasoconstrictor and sclerosing agents used to control a gastric bleed. But the question is, why was it bleeding? So we asked for the rest of that stomach. And what does it show? This is the reason he was bleeding. And what is this thing called? Yeah. I put the diagnosis up there. It is a Dieulafoy anomaly. And what is the Dieulafoy anomaly? Anybody heard about it? Somebody writing about it in the chat box? It is?
Not yet.
Not yet.
Yes, ma'am.
Yes, what is it? It is that a vessel which should be getting narrower and narrower as it branches to reach the mucosa, does not do that. That vessel maintains its caliber. So it is an abnormal caliber vessel which reaches right up into the mucosa. And if there is some reason for that mucosa to break down, whatever it is, there is sometimes catastrophic hemorrhage from this persistent caliber vessel disease. And this is what is known as the Dieulafoy anomaly. So he had a Dieulafoy from which he was bleeding. Whatever this necrosis was caused by the sclerosant, which is obviously an irritant, as chemical, as well as the epinephrine, which was used to try and control this bleeding. So he got an ischemic as well as a chemical disruption, extreme necrosis of the gastric mucosa, which looked like a tumor to somebody because it was spouting out above the surface. Is there any questions, Dia or Vimy or any of you who wants to ask on this condition? Yeah, Dia, anything?
No, ma'am, I understood, ma'am.
You understood it. Okay, excellent. And we come now to the last one. And who wants to take this? Come on.
Me, ma'am.
Who wants to take it?
Ma'am, Limpy, ma'am. Me.
Limpy, come on, Limpy. You're very keen to do it. I'm so glad. Come on, read.
Ma'am, 80 years old female, frail, complaining of soreness in the perianal and sacrococcygeal region. The primary care physician diagnosed as an impending bed sore and referred her to a surgeon. Ma'am, her main complaint was, ma'am, frequent stools containing blood and mucus and poor personal hygiene causing excoriation of the perineal skin and mucosa. Biopsy of a large ulcer in the lower anal canal was done, ma'am.
Very good. Now come on. We have to
Ma'am,
finish in 5 minutes.
in this
What is this you're seeing over here now? Limpy? Is it similar? We're talking about tweedle gum and tweedledee.
no, ma'am, here we can see, ma'am, extensive areas of necrosis only, ma'am.
Extensive areas of necrosis. Yes, very good. It's just faceless necrotic tissue. Okay. What do you see here? Same or something else?
Here, see, ma'am, here and see
Yeah, there are a few inflammatory cells, but
there
otherwise
can
it is
also
just necrosis. Yes. What do you see here? What is there here, Limpy?
Here's some
Some round things. Yes, structures. Okay, very good. Anything else? Trophozoites. What is this? Ah, yes, round specific bodies. Limpy, can you see that I marked something? All right.
Yes,
What is
ma'am.
that thing that I marked? What did I mark? You saw the trophozoites, yes. I can see this. I can see them. But what is this structure?
Ma'am, ma'am, eosinophilic slender material, ma'am. Like, ma'am, parasites.
Eosinophilic slender material. Can you describe that, Limpy?
No, ma'am.
No? No. All right, let's try. Suveta, what is that we are seeing? What is this? Sorry. What is it? What is it? What is the shape? Why can't you see a shape? Yes, Suveta, what's the shape?
Ma'am,
Suveta can't say the shape. Vimy, what's the shape?
ma'am, granuloma, ma'am.
Granuloma.
Organized collection.
Organized collection.
Circumscribed.
You don't see that there is a shape that looks as if it is circular. And then there is an area, there are several areas over here which have nothing in between. Okay, and then you see something that is densely pink inside, and also a lot of this inflammation is mixed up there. So, what do you think it could be?
Fungal hyphae.
Fungal hyphae. No, I don't think they are fungal hyphae. This is a blood vessel, no? That is thrombosed by this inflammation. And you can see that there are, and Limpy is right, these are trophozoites, and the trophozoites are actually entering into this vessel wall. So the trophozoites are inside the vessel wall. They have devitalized the vessel wall, you can see that, and there's thrombosis inside. So there is an inflammatory destruction of that vessel wall by this inflammation. And Limpy, you are right. These are trophozoites. Look at the trophozoites. The trophozoites of what?
Ma'am, these are, ma'am,
Trophozoites of what?
picture, ma'am, in this
Limpy, we can't hear you. What is the trophozoites of? Entamoeba histolytica. Yes. Yes, exactly.
Yes, ma'am.
Yes, Limpy, I heard you. Entamoeba histolytica. Okay. Now, Limpy, you were right. that this is Entamoeba histolytica. You can see that, and it's got you see the trophozoite, and then there is a clear space around it. Okay. Now it's there. You see this devitalized tissue in this case. Very good. What is the cause of this devitalization, Limpy? What has caused this
Infection, ma'am.
necrosis? You have all these
Infection, ma'am.
choices.
Infection,
Infection.
ma'am.
You think Entamoeba histolytica causes an infection?
Yes, ma'am.
Yes. You call it you are infected by amoebae. We say fungal infection. We say bacterial infection. Do we say amoebic infection? What do we say? Not really, right? So why has this been caused? By what? Why does Entamoeba histolytica have a area around it that looks clear? Why do you get this extraordinary, sort of destruction? And we talk about it, no, flask-shaped ulcers. Yes or no?
Yes, ma'am.
Yes, ma'am.
Why? So which kind of devitalization by which is this? Now we saw in the last case that it was chemical and vascular, both together.
Enzymatic, ma'am.
It's enzymatic, coupled by vascular, no? Because you saw the vessel there that was simply destroyed. So there is a vascular, and even in infection, it can't be an infection alone unless there is some kind of, like mucor. Mucor causes destruction of everything, including vessels. So yes, you're absolutely right. This is enzymatic destruction of tissues, and a very virulent kind of enzymatic destruction. And this diagnosis is anal amoebiasis. So very good, Limpy. You arrived at the right time, and you made the right diagnosis of Entamoeba histolytica in the anal canal. Okay, so that's the end of our talk. I thank you very much. It comes from the bottom of our hearts, from me, from Alice, from Tweedledum and Tweedledee. Okay, I hope there were some lessons to be learned, that things do look similar, but we have to sort them out. The underlying mechanisms may be similar, but the way that the diagnosis has to be worked out by observations and by interpretation. Okay? And as I tell you, students, I do not need you to reach the right diagnosis as long as you make the right observations. And if you've made the right observations, you don't know what something is, just look up the textbooks or put it into Google, and it's amazing how you will have found the right diagnosis just by making the right observations. Okay, so thank you very much, all of you. I think, as I told you, you had to fortify yourself with food and drink before you attend one of my slide seminars, but I do hope that it was worth it. All right then, thank you very much.
Thank you, ma'am.
Let me shut my page. I don't know whether I'm still there. Can you still hear me? Yes, I will stop my sharing, and then we can all meet. So, thank you, all of you. There's those who have sat out this very long slide seminar. I hope all of you have taken some lessons from it. Thank you, Dia. Thank you, Limpy. I'm sorry, Limpy, that we missed you a lot of the time. So, Suveta and Vimi, you've been a very interactive group of young people, and I hope you took some lessons from this. Yes? Thank you.
Yes.
Thank you, Ram and Bonita, and of course, always Ruchi. Thank you. Good night.
Thank you, madam.
Are there any questions in the chat box? I doubt it. Are there, Bonita?
No, ma'am. Actually, related to the necrotic part, many of them were thinking in terms of chemical injury and even
What injury,
causes.
sorry?
In relation to the necrotic ulcer case, which was just before the anal case, they were thinking of chemical injury, ma'am.
Chemical, Fevicol.
Yeah. No,
Very
chemical corrosive injury. Chemical
Yes, it is
corrosive.
chemical injury because the sclerosant has been put there. No, that's what they do for
How?
bleeding gastric ulcer when they're trying to sclerose the bleeding point. That's what they do. Yes, that is a chemical injury, and it is so very typical. When you see if you see it ever again, that's a chemical injury. All right. So we hope to see you again on Tuesday. I think you've got a treat with Vikram Deshpande, who's going to teach. He's an excellent teacher, so we'll see you on that day. Thank you so very much. Okay.
Thank you,
Thank
ma'am.
you. Bye.
Thank you.
Good
Bye.
night.
Bye.
Bye.
Right, ma'am.
Good night.
Bye.
Good night. Thank you. Thank you, Sri.